Okay.
We can go ahead and get started.
Okay, Susan?
So can we advance to the interpretation slide, please? Buenas tardes. Este evento será presentado en inglés y si no entiende el inglés, por favor seleccione el canal para español. Si usa una computadora, haga clic en el botón de interpretación o si está conectado por la aplicación de Zoom en su teléfono, haga clic en los 3 puntitos y siga las indicaciones en pantalla. No se puede acceder a interpretación a través de un Chromebook. Good afternoon. Today's event will be in English, and if you do not understand English, we ask you to please select the channel for Spanish on your screen. If you are using a computer, click on Interpretation, or if you are connected by the Zoom application on your telephone, please click on the 3 dots. Then follow the instructions on the screen. Interpretation is not available to Chromebook users. Y si no está hablando, ponga su micrófono en silencio, por favor, y al hablar, hágalo despacio y claro. Please mute your mic when you are not speaking, and when you do speak, please go slowly and speak clearly. Y queremos por último dar las gracias a los organizadores de este evento por ayudar a crear este espacio multilingüe. And we'd also like to thank the organizers of this event for helping to create this multilingual space. Thank you, and you can activate the interpretation. Gracias, y ya se puede activar la interpretación.
Okay, I think we can get started. So, buenas tardes a todos. Good afternoon to everyone. Welcome to this National Hispanic Medical Association presentation in association with multiple groups, and we will give credit to that at the very end. You will see our partners in this endeavor. We're today presenting on When Two Pandemics Meet, the HIV and COVID in the Hispanic LGBT community. Just as some background, my name is Judith Flores. I am a member of NHMA and I am not a past president, I'm a past chairwoman, so please don't give me that rank. I'm a practicing physician. I work in New York, mostly in Brooklyn. I have also been in leadership in organizing HIV practices and currently am involved in the COVID test and trace effort in New York. Just for background purposes, I want to make sure that when you are not speaking, please mute your device. We want to be able to listen well to our presenters, and we will have opportunity for questions at the very end. In background, just for our information, in 2018, the CDC presented findings related specifically to Hispanic Latino patients living with HIV and AIDS. This information showed that this group are among the most affected populations in the United States. Almost 1/4 of newly diagnosed HIV cases were among Hispanics in 2018, with a high rate in gay and bisexual men. Young people, young adults, and early seniors, that would be ages 21 to 35 and over 55, have had the greatest increase in rate. Hispanics impacted with AIDS and HIV have the lowest rate of access and retention to care and are being virtually suppressed in their viral load. Based on population studies conducted by the New York City Department of Health on elevated COVID-19 outcomes among persons living with diagnosed HIV in 2020, the evidence seems to point out once again that patients living with HIV and AIDS were hospitalized at a rate 40% higher when they had low CD4 counts, high viral loads, and this was directly linked to higher hospitalizations and ultimate deaths. Today on World AIDS Day, we are going to have the privilege to discuss the challenges as well as learn from our distinguished panelists what we can do to improve the health outcomes and lives of the communities that are living with HIV and AIDS. I want to thank all that have made today's event possible, and especially want to recognize the presenters who have taken their time and talent to care and teach many of us how to do this work. I want to start with our first panelist. Our first panelist today, I'm very happy to present Dr. Joseph Desantis, who's an associate professor at the University of Miami School of Nursing and Health Studies at Coral Gables, Florida. He's also the co-director of the Mental Health Disparities Core Center for HIV and Mental Health Research, also known as CHARM. His research focuses on the intersection of HIV risk and psychosocial mental health issues among various vulnerable populations, such as Hispanic men who have had sex with men, transgender women, and people with HIV infection. Dr. Desantis has lectured nationally and internationally on topics related to the care of HIV infected clients and their families. He is certified in HIV/AIDS nursing and HIV nursing certification board. Dr. Desantis is a member of the Association of Nurses in AIDS Care and the American Psychiatric Nurses Association. I welcome Dr. Desantis and would like to have him begin his presentation. Welcome, Dr. Desantis.
Thank you so much, Dr. Flores. Good afternoon, everyone. I'm very honored to present today to this on this webinar and to this very prestigious group. I would like to, before I start my presentation, like to give a little bit of acknowledgement to the organizations that have funded my research that I'm going to talk about today. The El Centro, which was our first NIH-funded research center at the University of Miami School of Nursing and Health Studies. I would also like to acknowledge the Miami Center for AIDS Research, or CFAR. Also acknowledge the Center for Latino Research Opportunities, or CLADO, at the School of Nursing and Health Studies. And also, of course, the Center for HIV and Research and Mental Health, or CHARM. So all of these have funded my research or have contributed to my research in some way. Next slide, please. So today, you know, when I was asked to put this presentation together to talk about, you know, the commonalities of two pandemics, a lot of things kind of came to mind, and I've kind of put together this little word cloud for you to show you the kind of commonalities between HIV infection and COVID-19. You know, and all of these were repeated, like when I was looking, you know, for this information, were repeated across multiple sites. And so I kind of wanted to share them with you. You know, treatment confusion, stigma, fear, discrimination, isolation, both physical isolation and psychological isolation, treatment controversy, denial, blame, social inequalities, inadequate government response, and disparities are all of the things that kind of come to mind. So what I'm going to be talking about today is, I'm not going to be talking much about research with COVID-19 because that's still in the infancy stages for me and for my team, but I'm going to talk about what we can learn from the research that I've already done with Hispanic men who have sex with men, or Hispanic MSM. Next slide, please. So to give you a little bit of context, my research has been situated in two sites, in El Paso, Texas, and in Miami, Florida. And I'm going to talk about some of the studies that we have conducted at both sites. But I wanted to give you a little context in case you're not, you know, familiar with these two different cities. You can see that the population of El Paso County, Texas, and Miami-Dade County are very different. And please note that the population of that I'm reporting for El Paso is just El Paso. It doesn't include the sister city of Juarez, which is immediately across the border from El Paso. So that would be a much larger population, but I'm only talking about El Paso because that's where we collected the data. You can see that the Hispanic populations are a little bit different in terms of the percentage for both cities. And the HIV cases diagnosed in El Paso was about 16.3 and 14.3 in Miami. And in El Paso, there's a slight increase in HIV cases. And in Miami, we are kind of holding steady. And then adding COVID cases, and again, this is from November 28th, there was about 85,000 cases in El Paso, 226,000 in Miami. And then you can see the deaths, a little over 1,000 in El Paso, about 4,000 in Miami. And the death rate for El Paso was about 1.3%, and it was 1.7% in Miami. So two very different counties, very different sites, but there are some commonalities that we're going to talk about, that I'm going to talk about throughout this presentation. Next slide, please. So we know that, looking at both the impact of COVID infection and HIV infection, there's an increased physical health burden, but there's also a really high mental health burden with both of these infections. And the reason that we're concerned about this is the physical health and the mental health burden combined have a big impact on what we like to talk about, the social determinants of health. And these are economic stability, education, healthcare access and quality, environment, and the social community context. So when we're thinking about both of these pandemics, we're thinking about how they put a big burden on physical health and mental health, but ultimately it impacts the social determinants of health for our participants. Next slide, please. So what I'm going to be talking about today, giving you a nice summary, I hope, I'm going to be condensing about 15 years of research with Hispanic MSM that used mixed methods approaches and really looked at the intersection of HIV and HIV risk and mental health. So you're going to see that, I'm very much, as Dr. Flores noticed, when she presented me, was that I'm very much interested in where mental health and HIV risk intersect. And so all of my studies that I'm going to talk about will include those components. Next slide, please. So I have to give a lot of attention to my El Paso team that we all work together to do this type of research in El Paso. Obviously, I don't live in El Paso, but I do live in Miami. And so, I was lucky to meet these incredible people, Dr. Mancera, Dr. Loza, Dr. Mata, and Dr. Provencio Vasquez, who helped me put together, our research ideas. And this team was really great, because not being from El Paso, I didn't really know the area. And they were really open to, my ideas and my research ideas. And we were able to work together and collaborate on some really amazing projects. Next slide, please. My Miami team, Dr. Cianelli, Dr. De Leon, and Dr. Valdez, we are currently working on a number of projects. With Dr. Cianelli, we're working on a project with PrEP for heterosexual Hispanic women. So these people are part of my Miami team that help with the research in Miami and also with the dissemination of our research results. Next slide, please. And I'm forming now a multi-site nursing research team from El Paso, from Colorado, Boca Raton, and of course Coral Gables. And we're going to be continuing to work on COVID and HIV related projects moving forward in the future. Next slide, please. I always like to give credit to all of the people who, who've worked with me in my research. So Research with Hispanic MSM with HIV infection. I'll start with this first because we did three separate research studies in Miami and El Paso that looked at the unique experiences of Hispanic MSM with HIV and HIV infection. And we found that the participants in the studies, in two of the studies, were at high risk for major depression and also high risk for substance use disorder. And these participants also reported histories of child and adult violence. And they also reported a lot of stress that was related to not only living with HIV infection, but also some of the social determinants of health were contributing to some of their stress. And we also found that a study in Miami found that HIV infected men had lower levels of social support and higher levels of drug use when they were compared with men who were not infected with HIV. And it was also very interesting for us to note that men who were not aware of their HIV status had more sexual partners compared to those who were aware of their HIV status. So what I'm going to lay out for you here in all these studies is kind of some takeaway messages that we can use for both HIV infection and COVID-19. Next slide, please. We also did a qualitative study in Miami where we looked at risk factors for HIV infection among Hispanic men. And these men, it was a qualitative study, so these men talked about, the twisted or the tangled branches. And they talked about violence, the burden of violence, and substance use and sexual risk as big issues in the Hispanic MSM community. And when they talked about what was the roots of this risk, if you think about the tree and the tangled branches or the twisted branches, the roots of risk were culture and acculturation, discrimination, economics, lacking psychosocial support, immigration, peer influences, and unstable and often violent intimate partner relationships. Next slide, please. So looking at that, which was kind of the basis for our research on HIV risk among Hispanic MSM, we were able to survey 125 Hispanic MSM in Miami, Florida, and we asked about the influence of their parents, how their parents reacted to their sexual orientation. And we were very much interested in the impact on depressive symptoms and sexual risk. And our findings indicated that rejection by the father or the mother because of sexual orientation resulted in depressive symptoms. And then the parental reaction to sexual orientation did not influence sexual risk behaviors. And this was an interesting finding for us because we do know that that depression, from our previous studies, we do know that depressive symptoms was related to high-risk sex among Hispanic MSM. So, it's important for us to think about, rejection of sexual orientation as a source of stress and a lack of support for these men. Next slide, please. Next slide, please. Okay, we also did two qualitative studies that looked at Hispanic MSM, and we found in these studies that the men had problems with sexual decision-making, as into whether to engage in unsafe or safer sex behaviors, and they also had difficulty with sexual negotiation. Next slide, please. And then lastly, a study by one of my colleagues that I participated in, Dr. Beatrice Valdez, looked at 150 middle-aged Hispanic MSM. And we reported in this study that unprotected anal sex was related to low levels of social support, increased loneliness, and increased depressive symptoms. Next slide, please. So we do have, and because of time I can't talk about this, but we also have data on 150 Hispanic MSM in El Paso and 100 in Miami, where we looked at the experiences of adverse childhood experiences, mental health, sleep, impulsivity, sexual compulsivity, PTSD, and sexual risk behaviors. And the results of those are currently being analyzed and studied. Next slide, please. So in summary, HIV infection and COVID-19 have the potential to affect Hispanic MSM. And we know that the combination of these two can result in depressive symptoms, decreased social support, loneliness that could lead to risk for violence, increased stress, mental health, substance use, and high-risk sex. And so more research is needed to understand how both pandemics affect physical and mental health of Hispanic MSM. And if anyone has any research funding they would like to send our way, we'll be happy to take it. Thank you very much.
Thank you, Dr. Desantis. This is, I see all your references, but this is a subject near and dear to all of us that are doing this kind of work. And I happen to be a pediatrician, so I really appreciate your reference to the trauma-informed childhood experiences that many of these patients have and how we can have an impact early on. So I'm going to move on now. I don't know if Mr. Fittick is here.
Yes, I'm here.
Oh, wonderful, wonderful. So welcome. I wanted to move on to you. So Arthur Fittick is a public health nurse leader and has been with the Visiting Nurse Service of New York program and is the director for their LGBTQ services. He has worked for over 4 decades caring for persons living with HIV and dying of AIDS. We are very happy to have him here with us today to share his experiences in dealing with some of the most vulnerable populations in New York City, who are once again impacted by a second pandemic and continue to face many of the same challenges as in years past. I can say many, many more things about Mr. Fittick, but I want to move on and let him do his presentation and use the time wisely. Thank you, Mr. Fittick.
Thank you, Dr. Flores. I wanted to thank Dr. Rios and Dr. Flores and members of the National Hispanic Medical Association for inviting me to speak today. My name is Arthur Fittick. I'm a gay cisgender male. My pronouns are he, him, and his. I'm joining you today from the borough of Manhattan in New York City. I first want to recognize all of you for the sincere dedication you have provided to your patients and communities during this challenging time of COVID-19 pandemic. My report today will be basically a report about the boots on the ground during the initial phases of the pandemic in our large urban area, and how, as an agency, VNSNY was able to help hurdle a lot of these barriers that were thrown at us. So just a quick overview, VNSNY is 127 years old. Our mission is to improve the health and well-being of people through high-quality, cost-effective healthcare in the home and in the community. Very often, home health care utilization is misunderstood during non-emergent times, but it's always a key player in New York's healthcare. VNSNY took on a critical role during the COVID crisis. And some of the unique aspects of our organization, as you can see through the slides, is that we have a powerful dual capability as being a provider with 127 years of our clinical expertise, as well as a health care plan with deep understanding of managing and financing care for complex conditions. this was very important during COVID. We have, as you can see, we have 12,000 employees roughly, and each day we service about 44,000 patients living in the New York City metro area. We've been able to speak 50 languages collectively by our staff members, many who come from various cultural backgrounds, which helps a great deal. Just during the year of 2019, we were able to provide $39 million for charitable care and community benefit programs to under and uninsured individuals, which in our environment is an incredible amount of people that we come across who are underinsured, especially now, or who are underinsured or just uninsured, period. Next slide, please. So a little bit of background with our collaboration with the LGBTQ community. We started really as being a pioneer on the forefront of the AIDS epidemic, meaning that we were able to really innovate many new care models during that time. And we were able to innovate and get reimbursement rates changed so that we could provide care for patients in their home during this time. And there was such an acute need for high-level care at that time that had never been requested before. We've done a lot of LGBTQ community outreach. We have collaborations and we have community partners who are about, I would say we have about 20 key LGBT partners in Manhattan, Queens, the Bronx, and in Staten Island also. We also have a gender affirmation program for patients undergoing gender affirming surgery. This is a very key development that we have. Our clinical director has trained over 200 nurses specifically to handle the challenges for those patients who are discharged after gender affirming surgery. We've been able to achieve platinum status credentialing from SAGE for our cultural competency. And again, as I said earlier, we have over 10,000 employees, including senior leadership, and we all stay current with the current SAGE training for cultural competency. We've been able to recently start our SOGI language training so that we can really complete our electronic medical records and start collecting data, which I'm sure many of you are aware is so badly needed for the LGBTQ population. We participate in the AIDS events across New York City, such as Pride and the AIDS Walk. We also started an LGBTQ employee resource group, which is called Out at VNSNY. If anyone's interested, you can just pop into that site. Next slide, please. Okay, so COVID-19 and HIV. I'm sure that you've heard that the COVID-19 and HIV pandemics started pretty similarly in terms of a very mysterious illness affecting those areas, geographic areas of really marginalized communities and of people of color. The New York public health disparities were evident before COVID-19 hit. During this time in the initial phases, many of the clinics and health centers were forced to really focus on HIV patient care. Clinics and centers turned into COVID testing and care centers, which meant that the HIV patients were not able to come in for their visits or for their lab work. Hospitals suspended routine care and barred visitors and outside staff, including our staff, from HIV supporting organizations to come into their facilities. Next slide, please. So this is just basically a really early snapshot of early data that started to show us where this pandemic was really going and what populations were really going to be hit the hardest. And we can see by this slide that the Hispanic community was really recognized and identified very early in the pandemic as this was going to be an area hit hard, and we were trying to really start to plan to manage this impact. Next slide, please. So with COVID-19 impact on caregivers and VNS clinicians, in community health and home health care, we rely heavily on family members and assistance by home health aides to really provide, the hands-on ongoing care to the patients in the community. And during COVID-19, of course, this was all stopped. Family members were not coming in. They were not allowed into some of the senior buildings. And the caregivers who were helping patients, were not able to respond to this need at that time for fear of their own health a lot of the time. So VNS-NY clinicians and home health aides put themselves at risk to do their jobs. And this really meant being out in the public, riding public transportation, again, not really understanding much at all about this pandemic, about COVID, but continually visiting their patients every day and using public transportation. And it was very challenging. There were very, very, special challenges with working in housing projects, with poor elevator service and poor health education for the community in those projects. We had to immediately change to online and internet training, which I'm sure a lot of you are familiar with and had to do. But we also had to require a great deal of PPE, which was difficult for us in terms of getting, because a lot of the PPE was being designated for hospital and healthcare centers and not home health care. But what we were able to do when we obtained it was the supplies and PPE were being sent to the home health aides' home, so they wouldn't have to come into the office and pick this up. Next slide, please. So again, it was, boots on the ground, thinking as we were doing and trying to create the best resources for our clinicians that we could. So in March, we established a team called the Cert Team, which was the Clinical Expertise Response Team. And this was staffed by RNs, our most experienced RNs, 7 days a week from 8 a.m. to 5 p.m. And the function of this team was to be the first line where staff could call for help, for assistance, for questions about symptoms, about getting into buildings, about what was being safe and what to do if patients or family were not wearing masks, how to treat these patients. Also, they provided telephonic outreach to our home health aides on the use of PPE, which was, a whole nother level of training that we had to do again on the, online for our home health aides to try to teach how to properly use PPE to protect themselves. Our education department developed numerous, just huge amounts of education material and videos very quickly on how to best, answer a lot of these questions that were coming up. And of course, the Cert team was able to track and trend data related to COVID-19 for management. So we could keep track of what was needed, what were the services being asked of, what were the needs of the staff, how could we best respond, and very importantly, how could we keep everybody safe, the staff and the patients. Next slide, please. So how VNS-NY helped during the New York hospitals cope. This was very challenging, as a very challenging situation as hospitals, of course, became overcrowded. The staffing was really being pushed to the max. They were running out of space, and they needed to discharge patients because so many more patients were coming in. And the issue, of course, was the acuity level of the patients who they were asking us to take after being discharged. And how could we handle this acuity level of patients to help the hospitals open up more beds? Again, this really involved a lot of training. This really involved, you know, a lot of support. Next slide, please. So we also, in our choice plans and in our healthcare plans, a lot of the members who are in those plans really see these healthcare plans as their family members, because there's such a close relationship to provide really guidance and support during this time. Next slide. We also moved to telehealth. This was something we quickly had to do to handle the patients who we had on service, as well as providing a lot of our staff being sent to those with a higher acuity level. And we found out that we also had to start, you know, increasing the amount of medications and prescriptions for a longer time period so that the patients would have ample supply during this time. Next slide. We were also able to develop a contact tracing tool. As many of you may know, in the beginning, the New York City Health Department had a lot of hurdles with their testing and tracing. And so VNSNY had developed their own, and you can go to this site and explore more about our contact tracing tool, which is free of service for anybody's use. Next slide. Looking ahead, just one thing I wanted to point out is that we're all learning from this pandemic experience together. We'd really like to share experiences and all learn together about this. I would also like to add one quick note about cultural competency, and that if we're not really recognizing our patients as their authentic self, then we're really denying them true access to care. But thank you very much for this opportunity, sharing this information.
Thank you very much, Mr. Fitting. And I'm going to move on to our next presenter, but I know we have many, many questions about what you just presented, especially those in New York that have used your services. So I'm going to move on to give us a time for discussion to introduce Captain Ken Dominguez. He's an officer in the United States Public Health Service Corps, a pediatrician and a preventive medicine specialist. He serves as a senior medical officer in epidemiology in the CDC Division of HIV/AIDS Prevention. His HIV prevention work at CDC focuses on biomedical intervention, such as PEP and PrEP, and he has most recently worked as a technical lead on the Ending the HIV Epidemic pilot project in Baton Rouge, Louisiana. I will go on to say that he has worked on CDC COVID-19 responses in various capacities since early February, when most of us got involved, including working as a quarantine medical officer and a clinical lead for CDC development, assessment, and monitoring. So I will now let Dr. Dominguez speak. I will cut his bio a little short because of time. Dr. Dominguez, you have the time to present your work. Thank you so much for being here.
Thank you, Dr. Flores. It's really a pleasure to be here. And I just wanted to say thanks to NHMA for the opportunity to share information about Let's Stop HIV Together and the Hiv Nexus projects, which represent continuing medical and nursing education to support the Ending the HIV Epidemic initiative. Could we please go on to the next slide, please? And so this campaign is part of the National Ending the HIV initiative from the U.S. Department of Health and Human Services, and is comprehensive with resources for both general and clinical audiences. And it focuses on topics of testing, treatment, stigma, and prevention. And here you can see for some materials for both consumers and some directed at providers. And we'll be talking more about those. If we could go on to the next slide, please. So this is the Let's Stop HIV Together website. And as you can see, I have both the English and Spanish versions with the links below each website. And this is really the central location for all campaign resources. It allows one to access resources by topic and audience, also to locate services, and then also to access other resources from the Division of HIV and AIDS Prevention at the CDC. And it provides also links for English and Spanish versions of the website at the bottom of this page, so you can see those if you want to access those directly. Next slide, please. So Let's Stop HIV Together campaign tailors its resources for general and clinical audiences. It addresses core clinical HIV topic areas, including screening, prevention, and treatment. And it also aligns very nicely with the goals of the ending the HIV epidemic to reduce new HIV infections in the US by 75% by 2025 and 90% by 2030 through testing, prevention, diagnosis, and responding to the HIV epidemic. Next slide, please. So now a little bit about Hiv Nexus, which is a new clinical resource. It's another component of the campaign and can be accessed at the link shown above. It's a one-stop location for up-to-date tools and guidelines across the HIV continuum for your practice, and also provides educational materials for your patients. And it also offers a comprehensive approach to improve health outcomes for people with HIV, regardless of sexual orientation, gender, or age. Next slide, please. So talking a little bit about COVID-19 and HIV, to address the shift in the way we provide HIV care and services during the COVID-19 pandemic, CDC has released resources that are available on the HIV Nexus link shown at the top of the slide, including guidelines on telemedicine, the continuation of PrEP and STD services, and also how to interact with patients during this pandemic. Next slide, please.
CDC has then what?
So this past summer, CDC released resources and a one-pager titled HIV Testing and PrEP Services during COVID-19 on the HIV Nexus website. And it encourages continuing these vital services to end the HIV epidemic, and also encourages clinicians to consider telemedicine as a modality in HIV prevention in this pandemic. Next slide, please. CDC recently created free clinician and patient materials for PrEP and PEP, which are biomedical prevention tools with high interest among primary care providers. We know that PrEP is a powerful tool for preventing HIV infection. It reduces the risk of getting HIV from sex by about 99% when taken daily. However, there's a need for more uptake in order to end HIV. We know that, for example, less than 25% or more than 1 million people in the United States who could benefit from PrEP are using it. Also, Black or African American adults account for approximately 40% of persons who may gain from PrEP, but are prescribed PrEP at only 1/6 the rate of white adults. Also, PEP has been shown to reduce transmission of HIV. It's associated with an 81% reduction in the odds of HIV transmission among healthcare workers with percutaneous exposures to HIV, but it's also an underutilized biomedical intervention. Next slide, please. So to encourage the clinical practice of PrEP and PEP services among primary care providers, CDC developed the Prescribe HIV Prevention Resource Kit. And this kit includes, for healthcare providers, an updated FAQ about PrEP and PEP services, and also a clinician's guide for discussing sexual health with patients. And for patients, it also includes waiting room posters about sexual health, as well as digital tools that support learning about PrEP and PEP via telehealth visits. And you can download free materials at the website at the top of the page. And the websites for downloading the PrEP and PEP FAQs are beneath each image. Next slide, please. It's imperative that providers make HIV screening their routine practice. About 1 in 7 people with HIV in the US do not know their serostatus. Recently, data about HIV diagnoses showed that 70% were due to male-to-male sexual transmission, 24% were from heterosexual transmission, and also we're aware that risk-based testing may fail to identify people with HIV, so CDC recommends routine opt-out HIV screening. In 2018, approximately 2 in 5, or 40% of patients in the US were already at the most advanced stage when diagnosed. Next slide, please. So some of the HIV screening resources provide CDC's latest HIV testing recommendations, guidance on testing technologies, including early detection tests, and patient brochures to use in your practice in English and Spanish, and also resources to link patients who test positive for treatment and partner services. And once again, you can download or order materials at the website listed at the top of the page. Next slide, please. Healthcare providers play an important role in linking their patients with HIV to treatment and care. By prescribing antiretroviral therapy, clinicians can help their patient with HIV stay healthy and prevent transmission to their partners. Also, to experience reduction in HIV-related morbidity and mortality at all stages of HIV infection. And finally, achieve and maintain an undetectable viral load that results in their effectively having no risk of transmitting HIV through sex, known as treatment as prevention, or TASP. Engaging patients with HIV in a brief conversation about the prevention steps they're taking can help them embrace their treatment regimen so they can have healthier lives. And so the website also includes some video links, so you can actually observe people talking to patients. Next slide, please. Furthermore, CDC's HIV Care is Prevention, a toolkit for healthcare providers, formerly the Prevention is Care program, was updated by the Together Healthcare team. It includes provider brochures to foster discussions between clinicians and patients about HIV care and treatment as prevention. And those materials can also be downloaded at the website at the top of the page. Next slide. So a little bit of information about some free continuing medical education programs. And we know that lots of times towards the end of the year, physicians are wanting to finish up their CME requirements. So here's some good tips on getting those CMEs completed. So the Together team with Medscape developed free online CME and also CE programs for both physicians and nurses. And the most recent course was released in July, and it will be accredited for medical and nursing contact hours for 2 years. The free continuing medical education programs include one that's titled HIV Testing, Prevention, and Treatment, a Stepwise Approach. And its goal is to promote multidisciplinary coordination of HIV screening, prevention, and care services to address initial and ongoing patient management. Also, advancing PrEP in practice, practical strategies for everyday challenges. Its goal is to improve primary care providers' recognition of patients who could benefit from HIV PrEP medications. And this training program is coordinated by CDC and Medscape and has been renewed for an additional year. There's also a new updated educational program based on an NMWR overview called PrEP for HIV Prevention Among Adolescents, Clinical Considerations 2020. The University of Washington and its affiliated AIDS Education and Training Center program has an updated national HIV curriculum, which is an outstanding resource as well. Next slide. So in the Medscape course titled A Stepwise Approach, leading infectious disease expert Dr. Paul Sachs provides an opening commentary, including some key scientific and surveillance data points. And the opening commentary is provided by a dynamic panel facilitated by Dr. David Malebranche, and is a video montage that showcases key points about coordinated HIV care. Next slide, please. So to broaden other aspects of HIV care, the Together team with Medscape Education created 2 additional free online CME and CE education programs. And that includes treatment as prevention, or TASP. And its goal is to inform healthcare providers about the benefits of TASP for patients with HIV and how to implement in clinical practice. The second one is HIV treatment and care, a focus on mental health and substance use. And its intended audience are physicians and nurse HIV care providers. Its goal is to provide patient care for patients with HIV and mental health and/or substance use disorders. And there are also video clips for your awareness as part of this Together curriculum series. There's also something called the Stepwise Approach Panel, which includes Dr. Myron Cohen, who is part of who works on the treatment as prevention part, and then Dr. David Hardy, who is part of a focus on mental health and substance use. Next slide, please. Now a little bit about transgender health. The Together team developed products tailored for priority audiences. The transgender people face many obstacles that affect their ability to stay healthy and put them at risk for getting or transmitting HIV. The following are the proportions of transgender women who have HIV. Overall, 1 in 7. Among Black and transgender women, 1 in 2. And among Hispanic transgender women, 1 in 4. So providers play a role in closing the gap by delivering patient-centered HIV care. And you can download these materials at the website listed above. Next slide. So the next is transgender health resources, additional resources, and these include addressing the disparity among transgender women through resources that allow clinicians to provide HIV care, including building a patient-centered care environment, collecting sexual orientation and gender identity information, taking sexual histories, and conducting HIV testing. And those can also be found at the above listed website. Next slide, please. So at this last slide basically just provides some information where physicians and other healthcare providers can join the Ending the HIV Epidemic conversation on social media by following the Division of HIV/AIDS social media handles on Facebook, Twitter, and Instagram. And this slide includes the social media platform that we actively utilize to disseminate our Let's HIV Together campaign messaging, as well as other relevant HIV resources and updates. And this content is in English. On occasion, just wanted to mention that the campaign also leverages CDC and Espanol platforms to share Spanish language content. And it's important to note that our Together campaign has a robust set of English and Spanish language materials appropriately sized for various social media platforms. And for more information, please email stophivtogether@cdc.gov. And I just wanted to finish by thanking the NHMA for allowing CDC to present on these valuable resources. And also thanks to all of you for your time. For further inquiries, you can contact the Together team at stophivtogether@cdc.gov. Thank you so much.
Thank you so much, Dr. Dominguez. Thank you very much. This is just full of research and resources for all of us who really take care of patients directly. It's a major challenge to get physicians to understand what PrEP is about. And considering the 2 pandemics, it is an opportunity to get people on PrEP and really safeguard their health. So I'm going to start with some questions. I have one question right away, and it is actually from me. And it's, if you had to pick, this is for all the panelists, if you had to pick one modality that would be most helpful to engage patients in HIV care during this pandemic, what would it be? One modality. I'm going to start with Dr. Dominguez because he's the first one on my screen.
Great. Well, I've had some experience in witnessing what's has gone on as part of the Ending the HIV Epidemic pilot project down in Baton Rouge, Louisiana. And I think one of the most exciting, innovative activities was the use of what were called rapid navigators, which were persons that once a person was diagnosed with HIV, a person from the health department who was a rapid navigator was assigned the task of contacting that person that same day, and the goal was to initiate linkage to care within the first 7 days after diagnosis.
Yeah.
And they were quite successful at doing that. And part of that was that the navigators were persons that were representative of the community. They had a passion for working with the clients, and the clients could see that directly when they made every effort to reach them. wherever they might be, and also, you know, to do it in a confidential manner so that they felt comfortable and secure with the outreach that was being provided. And so we were quite successful in linking folks to care. Typically the goal is within 30 days, but for this particular one, it was within 7 days. And we had some people same day starts.
That's excellent.
Treatments. We're very excited about
Excellent. That's excellent. Dr. Desantis?
I kind of think about, when I think about what we can do for patients, provide as much support as possible. You know, either providing support as a healthcare provider, and of course referring for mental health services when necessary. I think that's really important, and I think that sometimes we forget in HIV care. We don't forget, but we kind of think about, you know, the HIV medications and everything, you know, as paramount, and we kind of forget about the stigma and everything that comes along with HIV infection that really impacts our patients. And so I think providing as much support as we can and also referring them for support is very important.
Mr. Fitting?
I would just say also the increased behavioral health services has to be addressed. One program that we have that works very well in our Select Health program is peer outreach. And what this does is it reconnects people who've stopped taking treatment, or who've lost contact, or who've been, you know, evicted from their apartments, are unlocatable. So we have a peer outreach team that goes out physically looking for patients to reconnect them to care. And that's been very successful.
I also want to ask, there's a question that came up in the chat. It was directed to Dr. Desantis, but it can be answered by all. How do you share your experiences with other clinicians? How do you get that information out? I see that CDC has many, many tools, but a lot of us that are, you know, doing direct care and working with physicians and trying to, believe it or not, convince them that PrEP is something that really should be pushed out and offered and supported. How do you get your ID specialists, your other clinicians, around the idea that remarkably, this is a way to end the epidemic? I want to start with Mr. Fittick because he went last.
We really have a very open dialogue and share a lot of information with all of our clinicians, our mental health and behavioral health group, you know, our hospice unit. We really come together and share ideas and experiences about, especially about COVID and HIV, what's been happening. And you know, we really encourage our clinical staff to start writing down their experiences so that we can keep a written record and share with everybody.
Okay. Mr. Desantis? Same question.
I would say talk about it as much as possible. I never turn down an opportunity to talk about this. So if someone invites you to talk about it, you know, to talk about your research experiences or your clinical experiences, I think that's the best way to get the information.
That's good. Thank you. We actually have on the chat a reference to Whitman Walker Health in Washington. Apparently they have a very good success rate with Rapid Start. So I guess you can get on their page and learn. We can learn more. Just some final remarks. If any of you would like to give us some final remarks. We don't have any more on the chat at this point. I do want to wrap up, but if you have any final remarks, then I will end the session with you and with a remark that I'd like to make.
Hi, this is Ken Dominguez, and I just wanted to emphasize one point for providers when educating patients during the COVID pandemic, especially for those patients that are trying to prevent HIV infection, is to encourage them to continue to take the PrEP if that's something that they're willing to do during this pandemic.
Definitely.
Regardless of whether they're having less sex, but it's really critical that they keep those daily regimens going, because we know that starting and stopping, currently CDC does not recommend stopping and then just suddenly let's say, oh, it's Friday night. It's time
No.
to take my prep. That's not going to work. So
It's too late.
really, it's important that people understand why that's the case and the science behind that.
That's an excellent, excellent point. So I want to thank all three of you for being part of this panel. I know I've learned a lot, and it's spoken to a lot of things that I've done in practice and in delivery of care. I do want to honor that today is World Health Day, and I want to honor those that we've lost, both to HIV/AIDS and to COVID this year. But the best way to honor them is all this positive work that's going out there. I never would have believed that HIV could be undetectable and untransmittable. And one day, COVID will be treatable. So thank you very much, all of you. Buenísimas tardes. Adiós a todo el mundo. Good night.
Bye.
I think we're